what are the side effects you come across when you're using ARNI? Number one. Number two, the patient has been already taking ACE inhibitors. Theoretically, if you are going to initiate ARNI, it is likely to have more of a bradykinin accumulation and a problem. How will you manage it?
Right. See, bradykinin accumulation clinically, I'm coming to the second question, is clinically manifest by a dry irritating cough. Majority of patients with ACE inhibitors would show that. That is at least about 5 to 10% of people. With ARB, you don't get that one. But similarly, when you start using ARNI, you don't get to see a sizable number or proportion of people getting the symptoms of bradykinin. You only get the good effect of bradykinin, that is vasodilatation, and therefore the improvement in reduction in preload, and therefore improvement in ejection fraction. And the first question that you asked is?
The side effects we come across with ARNI.
See, when ARNI was introduced in 2014 after the Paradigm HF trial, in majority of the lectures that we used to go, they used to say we are afraid to start because the blood pressure is 100/70. One of the most important thing with ARNI is, if you should not be chicken-hearted, you should be really lion-hearted. Start using them in 50 milligram half BD. And majority of them, the cardiac failure comes down, their blood pressure improves. And then you can slowly step it up to 200 milligram BD. Majority of my patients, I have never exceeded 100 milligram BD, even though the guideline says 200 milligram BD. With 100 milligram BD, they all do very well. So the initiation itself is very difficult because majority of patients with cardiac failure will have a low BP, 100/70. I have started in most of the patients hospitalized pre-discharge when the blood pressure is 90/70. Only thing is we have to be very careful whether we are going to have an hypotension. If the patient complains of postural hypotension in the beginning, we will have to tell him the modalities to say. And one more important take-home message is, you start the patient on ARNI, patient improves, but there is hypotension, reduce the dose of diuretic. They will be stabilized very well.
So when the patient is already on ARB or ACE inhibitors, is it right to stop the ACE inhibitors for 24 to 48 hours before you start the ARNI?
The guideline recommendation ever since the drug has been introduced is stop ACE inhibitor or ARB for 36 hours and then start it.
Sir, that's a wonderful presentation. My question is like ARNI as an antihypertensive agent, what is the data upcoming, sir? Because it has potent blood pressure reduction, which can reduce LV remodeling.
I won't call it as potent because even in, we are using ACE inhibitor for reduction of blood pressure. The reduction of blood pressure in HOPE trial itself was only 7 to 4 millimeters of mercury. Similarly, with ARNI, it is 4 to 2 millimeters of mercury, just like SGLT2 inhibitors. So I won't call it as a potent, but they are trying it out in resistant hypertension as an add-on therapy. But with all the calcium channel blockers, beta blockers, and the ARBs, we are able to reduce in most of the patients, failing which all of us have started using the alpha blockers.
What is the safest renal parameter? Creatinine allow one, sir. Second, once patients improved and stabilized, can I reduce the ARNI level, sir?
Don't ever reduce the ARNI level. Don't ever reduce. If you reduce, you will be in a problem. In a few patients, I have stopped ARNI. They are all peripartum cardiomyopathy who have come on to above 55% ejection fraction. When they do not reach above 55%, it is only taking a risk if you reduce any of those recommended drugs.
What about creatinine level? Safest creatinine level?
Creatinine
High.
level.
Yes, sir.
Creatinine level, as I have told you, because less than 2.5, we are safe to give it. Because most of the nephrologists prefer it.
Oh.
Like they like ACE inhibitor and ARB. Even though the guideline says don't combine both, they are the only persons who would combine both and still be successful.
Thank you, sir.
Just regarding uptitration of medications, will you simultaneously uptitrate all the kind of anti-failure medications or go one by one?
I normally give very minor doses of beta blocker. So I don't uptitrate it. I either give 12.5 milligram of metoprolol or 1.25 to 2.5 milligram of bisoprolol. So I don't uptitrate it. and 25 to 50 milligram of eplerenone or aldactone, I don't up titrate it. So with careful monitoring, and SGLT2 starting itself is non-diabetic 5 milligram of DAPA and or 12.5 milligram of EMPA. So what requires to be up titrated is only mainly ARNI, with very due care on, as Sir has asked me, on blood pressure.
So not even the beta blocker. I mean the
Unless the person has got a persistent tachycardia. Even then, we are worried about the BP. We add a ivabradine along with the fixed dose of beta blocker. Unless the BP is very good, then you can go and increase the beta blocker. BP and pulse should be good.
thanks.
In a post-infarction setting, ARNI, what do you think, sir? Starting ARNI, post-antiretroviral infarct.
The Paragon HF trial was conducted in post-infarction patients just to find out the safety of ARNI, and it has been found to be very, very useful. In majority of patients, I have started using post-infarct patients when their BP is, as I told you, 170, when I shift them from ICU. And it is very, very safe.
Thank you.
See, regarding the beta blockers, there is, it itself is a very big discussion in itself. Actually, Sir said was correct in whenever your BP is low in the sense 100 systolic, but your BP crosses 100, you have to go upon beta blockers. I am a beta blocker man. Okay, so the thing is that, yeah, the target dose is very high. The thing is that you look at physiology, you look at cardiac output. So forget about all the data, forget about pulse, forget about your BP, all those things. What you are targeting in a HF-ref is a cardiac output. So you have to get the cardiac output to the maximum. The two pillars which are must are beta blockers and ARNI. So not even AC inhibitor or ARB. Now with ARNI, AC inhibitor and ARB, we now know that they are not that useful. Okay, so it is beta blockers plus ARNI. Okay, so cardiac output first increases with beta blockers, you get the heart rate below 90. So once you go up on beta blockers, still your heart rate is below 90 and above 55, 60 should be okay. That's your target beta blockers. Then once you have sufficient beta blockade, like say get down the heart rate to 100, then you go up on your ARNI levels to the maximum. Because once you start ARNI, your cardiac output increases to great extent actually. The patients will be asymptomatic, you can even withdraw the loop diuretics, you can just be on the 4 pillars, whatever is needed. Many of my patients need only these 4. I have almost stopped using beta blockers in chronic, stopped using loop diuretics in chronic patients. So the notion is you have to go up on beta blockers and ARNI, depends on the situation. So if the heart rate is high, go up on the beta blockers. If your cardiac output is needed to be increased, you go up on the ARNI. That's a way to do it.
I would agree with Sir. Slowly we can, once the patient is stable, slowly we can withdraw the diuretics. Because diuretics do not reduce the mortality like digoxin. They are only to unload the patient. Instead we can build upon the other 2 drugs.
Thank you, sir. Thank you for the wonderful presentation and discussion.